Thank you very much. My name is Sophie Doran. I'm an Esophagogastric Cancer Fellow from Sheffield in the United Kingdom. I'd like to sincerely thank the SAGES Committee for the opportunity to present our paper today on the risk factors for and the treatment of anastomotic strictures after Ivor esophagectomy. First thing to say, myself and my co-authors do not have any conflicts of interest to disclose. So Ivor esophagectomy is the most commonly employed surgical approach for esophageal and gastroesophageal junctional adenocarcinoma and squamous cell carcinoma. Survival rates following esophagectomy are steadily improving over time, but it's still a highly morbid operation with a morbidity rate which can reach up to 60%. There's a lot of emphasis on the literature and research in the major short-term complications of an esophagectomy, but I would argue there's a little bit less focus on the risk factors that impact on quality of life, such as anastomotic strictures, which are common and would have quite a variable incidence reported in the literature between 18 and 42%. Anastomotic strictures following an esophagectomy most commonly present with dysphagia, but they can also present with food bolus obstruction, such as demonstrated in this contrast swallow. They can, of course, also present with aspiration pneumonia and excess weight loss. As we all know, there are many different ways of performing the anastomosis in an Ivor esophagectomy, and not to make too much of a sweeping statement on the literature, I think it's fair to say that there isn't one single gold standard technique for performing the anastomosis. In terms of considering the risk factors for the development of an anastomotic stricture, well, there are several risk factors that have been implicated. The most strongly linked are those of ischemia and tension at the anastomosis, which of course have a close interplay with developing an anastomotic leak immediately post-operatively. But other risk factors which have been implicated in the development of anastomotic strictures include reflux of gastric content, specific operative factors such as the anastomotic technique and the anastomotic size in the context of a circular stapled anastomosis, and also patient factors such as demographics and neoadjuvant treatment. There's less known about what the impact of such operative factors as the presence or absence of a hyaluronic drainage procedure or the impact of preoperative weight. And there's a little bit less studied in terms of the long-term outcome of anastomotic stricture treatment. So the aim of our study was to evaluate the rate and risk factors in our cohort for anastomotic stricture following esophagectomy using a standardized circular staple technique. And we also wanted to look at the impact of treatment with endoscopic balloon dilatation on post-operative weight loss. We performed a retrospective cohort study of all patients in our institution, which is a tertiary referral centre for esophagogastric cancer in the UK, over an 8-year period. And for the analysis, we divided our patients into 2 groups according to those who developed an anastomotic stricture and those who didn't. We collected data on what we would consider the demographic risk factors for the development of a stricture, the operative risk factors such as the circular stapler size and the presence or absence of pyloroplasty, and also we collected data on the clinical outcomes. In our cohort, we defined an anastomotic stricture as one that's identified in the presence of dysphagia or stenosis at the anastomosis, either on an oral contrast study or at the time of endoscopy, and required endoscopic dilatation. And we did this with through-the-scope balloons. We dilated patients until they had clinical resolution of symptoms. In terms of our operative techniques, so we perform a standard transabdominal and transthoracic Ivor esophagectomy with a 2-field lymphadenectomy. Our cohort includes operations performed by one of 2 surgeons. In our cohort, one of our surgeons, as a matter of standard, performs a pyloroplasty, a Heineke-Michelix technique, and the other surgeon doesn't. We perform a standardized supraazygous circular stapler anastomosis with a Medtronic EEA circular stapler with anastomosis sizes of 25, 28, or 31. And we have a standardized post-operative protocol with all patients receiving proton pump inhibitors. There were 207 patients in our cohort, and the anastomotic stricture rate overall was 17.4%. Looking at the groups, so comparing the stricture group with the no stricture group, there was no difference in terms of the patient demographics, so age, gender, ASA grade, preoperative treatment, and their preoperative weight. There was also no difference between the 2 groups in terms of tumour demographics. Moving on to consider the etiology of the risk factors and our results. So we first considered pyloroplasty. So in our cohort, 115 patients had a pyloroplasty, and 92 did not. The anastomotic stricture rate in those who had a pyloroplasty was 13.9%, and it was 21.7% in those who didn't have a pyloroplasty. This was not significantly different. Our overall anastomotic leak rate was 9.7%. And in our cohort, although there was a trend to a higher leak rate in the stricture group of 25%, the stricture rate in the group that didn't have a leak was 16.6%. This wasn't statistically significant. Moving on to consider operative factors. So by far, the most common stapler size in our group was 28 millimeters. 72% of patients had a 28 millimeter anastomosis. And this had a significant impact on stricture rate. So if you had a 25 millimeter anastomosis in our cohort, a third of these patients developed a stricture, whereas if you had a 31 millimeter anastomosis, the stricture rate was only 4.8%, and this was statistically significant. In terms of clinical outcomes, there was no difference between the stricture and no stricture group in terms of the 30 and 90-day mortality. We looked at only major respiratory complications, so Clavin-Dindo 3 and above. We found that there was a lower incidence of major respiratory complications in the stricture group. Weight loss at 1 year post-operatively was no different. We then looked at endoscopic intervention. So 17.4% of our patients required endoscopic balloon dilatation. A third of patients only required one session of endoscopy, and 2/3 of patients required more than one session, with the maximum being 8 dilatation sessions. The median time to first dilatation was 3 months, and the time to last dilatation was 6 months. The median diameter of the last dilatation was 20 millimeters. There were no complications relating to endoscopic balloon dilatation of anastomotic strictures, and I emphasize again, there was no difference between the stricture and no stricture group at 1 year in terms of their weight loss. So to summarize our results, we demonstrated an anastomotic stricture rate of 17.4%, and in our cohort, the only risk factor for anastomotic stricture development was circular stapler size. We didn't find a difference in terms of clinical outcomes, and really I think that makes sense. It's most likely that the development of an anastomotic stricture is a multifactorial process. It's a common process, it's a common event, and really the focus should be on what we can do to treat it when it occurs. We showed that with a driven approach to endoscopic management, we could resolve dysphagia quickly and not have an impact adversely at 1 year in terms of weight loss. So to summarize, post-esophagectomy strictures are common. They're not always related to leaks or the presence or absence of pyloroplasty. And in our cohort, smaller anastomosis size was strongly linked with stricture formation. And we demonstrated that a proactive approach to managing strictures can be effective in minimizing excess weight loss. Thank you for your attention.